The final webinar in our series, Let's Talk About Epilepsy Surgery, is how do parents make the decision on which type of surgery your child should have? And I'm really honored today to be here with Dr. George Ibrahim from Sick Kids Toronto. He's a neurosurgeon who's part of their core team. Dr. Ibrahim, perhaps you could quickly share the other initiatives you work on at Sick Kids, and then we'll discuss how you make a decision between removing parts of the brain that control function called eloquent cortex, or going with a device known as a responsive neurostimulator, which is relatively new. Dr. Ibrahim, welcome.
Thank you so much for having me. It really is my honor and my privilege to speak with you. I'll tell you a little bit about me. I'm a pediatric neurosurgeon up in the Great White North in Toronto in Canada. And my main area of focus and interest here is the treatment of epilepsy through surgery. I'm part of the comprehensive epilepsy program at Sick Kids, as you heard from Monica. And I also have a research lab through the Institute of Biomedical Engineering at the University of Toronto, where I apply engineering principles to try and understand how some of the therapies that we have for epilepsy work, how they affect the brain, and also how epilepsy itself affects the brain in different ways. What we'll talk about today, of course, as you heard, is a little bit about decision making, which is much more nuanced and much more, in many ways, important to families. And this is an interest of mine as well, and this relates to a particular focus of mine, which is ethics in pediatric epilepsy surgery, ethics and value-based decision-making. So it really is my great privilege to have this conversation, and you know, any decision between a family and a surgeon is just that. It's a conversation. So I'm glad that we're having this today, and I'm very, very honored to be a part of this webinar series.
Well, thank you so much for joining us. Oh, let's see. Here we go. So the first thing we'll discuss is what is eloquent cortex. I didn't really understand what this was years into my son's multiple surgeries. So if you could share with our family what that means.
Yeah, so, you know, obviously when we're talking about surgery in the brain is a very, very prime real estate in the human body. And you know, you probably know the adage, we don't use all our brain, we use about 10% of our brain. This is something that we're all familiar with. You know, there's really no part of the brain that isn't important. All of the brain is important, of course, but there's certain parts of the brain that are responsible for controlling very, very critical functions that we value and we place a lot of emphasis on in our day-to-day activities. And this is a slide here of some of the examples of eloquent brain areas, and that's what's meant by eloquent. It's the parts of the brain that we place a very high value on in our day-to-day function. We have here the primary motor cortex, which is, of course, responsible for controlling movement on the opposite side of the body. The primary sensory cortex, which is responsible for controlling sensation on the opposite side of the bodies. The visual cortex, which allows us to see visual fields on the opposite side of our vision. And on the dominant side of the brain, we have language areas such as Broca's area, Wernicke's area, auditory brain regions, all of which are really quite critical. Now, there's other important brain regions that are also very, very important that form networks that help us with cognition. And these include the prefrontal cortex, some of the premotor cortices, association areas of the brain, for instance, in the back between the parietal and the temporal and occipital lobes. Those are secondary areas that are also very, very important. There's no part of the brain that isn't important. All parts of the brain are critical, but the eloquent brain regions are areas of the brain where there's specific function that we place extremely high value on, that we prioritize because they're so fundamental and so critical to our everyday activities.
And it would seem that some parts, at least personally, from family to family, would be more important than others. I would assume just about everyone would consider vision to be very important. So losing part of your vision would be a concern. Over losing hearing in one ear or how you process it might be less of a concern. And obviously, these are conversations to start having with your surgeon on what's important and what's not, right?
Absolutely. You know, there's a lot of values that go into prioritizing importance, but also all of us start in different places. So some individuals, some children, or some adults may have deficits in certain brain areas. So for instance, if a child has an injury at a very young age to the motor cortex and there's already some weakness to that part of the body, then maybe the importance that's placed on that part of the brain is less because that child is functioning very well with weakness on that part of the body that's controlled by that brain region. So the idea of importance and the idea of eloquence and the idea of prioritization of value to different brain regions is really individual. And different patients place have different priorities over what is considered eloquent based on where they are, where they start off, what abilities they have, and also what their values are.
Great, thank you. So you developed this model of when you have a situation where you're looking at resecting part of eloquent cortex versus this new device, the NeuroPace device, responsive neurostimulator, on how we should perhaps think about the decision making. And it involves sort of these three considerations, or kind of this kind of an overview, I guess. No, not, it's just an explanation of the decision first.
Yeah, so, you know, historically, when all we had was resective surgery, that was the only tool at our disposal. You know, our conversation was, should we proceed with surgery or should we not? For instance, if there was an area of focus in the brain that was causing seizures, say in the sensory cortex, and we were able to remove it, would the sensory loss on the opposite side of the body be a reasonable deficit to accept in order to have a chance at seizure freedom with the resective procedure? And these are conversations that we had and we continue to have with our families and with our patients every single day. Every single decision to proceed with surgery is a conversation, and it takes into account the child and the family's experience with epilepsy and how severe it is, the values of the family and the children, and of course, the recommendations of the epilepsy surgery team and this discussion that is really bi-directional that we have together. Now, what makes it a little bit more complex is now we have other treatments. You know, it's not just resective surgery that's available to us. We have increasingly increased our armamentarium of tools that we're able to offer families to potentially try and control seizures. And one tool that's emerged, as many of you know, is responsive neurostimulation. And for those that maybe are a bit unfamiliar with it, it is a tool where instead of removing brain regions, we place electrodes either on the surface or in the brain, in the area of the brain that's generating the seizures, and we deliver small electrical stimulation to that area instead of removing that part of the brain. And where it's perhaps most effective or most applicable is in parts of the brain that we cannot remove. For instance, in eloquent brain regions, if we have the option of stimulating it rather than removing it.
Would you go over the device a little bit here? This is the NeuroPace device. and it looks like it's implanted in the skull, and then there are these two leads that go inside, correct? It's into the brain.
That's right. So this is the setup of the NeuroPace device. And these are some of the most relevant characteristics of the device. So it requires one or two epileptogenic areas. And because there's only two parts of the device that could be implanted in the brain, if there's more than two areas that are involved in the seizures, then this device is potentially not as helpful. It is approved in the United States for individuals over the age of 18, but it is used off-label for younger children, and there's more and more evidence that's accumulating in this population, of course, off-label. It does require that the skull be fairly developed because the device is implanted in the skull itself, and then the electrodes are then placed inside the skull in the parts of the brain that are generating the seizures. And as I was alluding to earlier, it delivers electrical stimulation that then interrupts the spread of seizures. And as I mentioned prior, historically, our only other option was really to remove that part of the brain if we can find it. This gives us a second alternative instead of removing it, to deliver electrical stimulation that can then interrupt the seizure spread. This does not work in everybody. And in fact, as we'll hear about in a second, it's fairly new. So we don't know the long-term outcomes of this device, particularly in children. Some of the early data suggests that there's about a 40% seizure reduction. And of course, this factors significantly into the decision-making, as we'll talk about, and factors into the conversation that all clinicians have with families in trying to decide together what is the best treatment for the best child. The last point, please.
So just the two leads, so the device is implanted into the skull, so that's one part of the surgery, but those two leads would also require a smaller craniotomy in a different area to put those leads in, correct?
Exactly, that's right. So the device itself and the battery that delivers the stimulation lies inside the skull, and then through small openings in the skull and in a different area, those two leads would then pass inside, and they would then stimulate the inside of the brain, and in this particular case, in those eloquent cortices that contain function that we would not want to disrupt.
Okay. And then you were going to say something about it being reversible, but it does require more surgery to take it out.
Yeah. And that's correct. So one advantage of this procedure is that it is potentially reversible, that you can turn on and up, or you can turn down or off the stimulation over time. Whereas if you were to do a resective surgical procedure to remove a part of the brain, obviously that is a permanent procedure that cannot then be reversed in the future. And that is, of course, a consideration for families, and that also factors into the conversation when it comes to deciding which procedure is better for which child.
Okay. So let's talk a little about your framework for decision making. You have four sort of main areas, and then we'll talk about the pros and cons of, or the things that we have to weigh in each area.
Yeah, so let's talk about frameworks first and what frameworks are, because sometimes when you're faced with a decision, obviously at the end of the day a decision is usually made, and that decision is either this or that, it's A or B. But it's often easier to break down really complex and difficult decisions that are really, really tough to make into smaller little pieces. And when you break down those decisions into smaller little pieces, then sometimes that actually helps in paving the way for the final decision to be made. It's kind of like if you're making a really tough choice, sometimes you make a list of pros and cons, and you write down all the things that are under the pro column and all the things that are under the con column, and then it gives you an ability to reflect on what are the pros and what are the cons of the different alternatives that you're faced with. And this is what our decision-making framework attempts to help with. It attempts to help with breaking down the larger decision about what to proceed with into smaller little decision points. And based on those decision points, you can then explore which option is more suitable for which individual child.
That's great. They're such excruciating decisions for a family to have to make. So taking smaller bites seems easy, a little bit easier.
Yeah, of course. And again, I have to emphasize that all of these decisions, the small ones and the big ones, are all a conversation. And they're a conversation with the neurologists and the neurosurgeons, because we are here obviously to provide a recommendation and provide options, but we're here to support the family. That's what we do, and that's what we train for, and that's what we love to do. That is the greatest joy in our careers. It's to support families and to be there through these tough decisions. These are not decisions that any family makes on their own. And when we break it down into smaller little steps, sometimes this big, daunting, difficult decision becomes a little bit easier.
Yeah. So let's go through a couple of the steps here. The first would be goals of treatment.
Yeah. So these are some factors. Those are some little steps that we felt were important to consider in that list of pros and cons, in those little smaller decisions that can then be put together into deciding which treatment is most appropriate. So first is the goal of the surgery. So with resective surgery, the goal of the surgery, when you remove the part of the brain that's responsible for generating the seizures, the goal is seizure freedom, getting rid of seizures completely. Now, of course, we don't reach that all the time. Sometimes we reduce the seizures, and thankfully most of the time the seizures are gone or reduced, and sometimes we're not successful at doing that. But our goal is to achieve seizure freedom. But that comes at a cost, and the cost is a risk of deficit. And the exact risk of deficit depends on where the seizure focus is relative to the eloquent cortex. In some cases, the risk of deficit is 100% if we know that the seizure focus overlaps completely with the eloquent cortex. In other cases, the risk of deficit is less, and often the risk of deficit is the risk is of temporary deficit that improves over time, especially in younger children that have a greater capacity for neuroplasticity, or if the seizure focus is more removed from the primary eloquent cortices of the brain. RNS, on the other hand, really is a treatment that has a different goal. The goal of RNS is to reduce seizures. There are some very, very good responders to RNS, and we're getting more and more data on its efficacy, but it remains that RNS is not a treatment that is meant to achieve seizure freedom, only to reduce the seizures. And that's balanced against a smaller risk of deficit, but of course, weighing in what the benefit is of seizure reduction rather than seizure freedom is important to consider.
Yeah, yeah. And then looking at long-term outcomes, we know resection are generally, we have a lot more data on that, and then not quite enough in RNS. So
yeah, precisely. So resections have been performed for epilepsy surgery for many, many decades. And we have very, very good outcomes. And we can say, based on thousands of procedures performed, this particular outcome is going to be 70% chance or 80% chance based on our experience with thousands of procedures performed. Families that choose to do RNS choose to go down the RNS route, do so for a good reason, but there has to be an understanding that the long-term outcomes of RNS are just unknown because it's much more novel. It's much newer than the resective procedures. That's not to say that it's not a reasonable option. You know, we often make choices to pursue different avenues that are new, and sometimes that's a good thing, be it, you know, a new medication, be it a new device. Sometimes that's a good thing, but we need to know that what we don't know what we don't know, and there are gray areas when it comes to RNS because we don't have that base of evidence to tell us exactly how things are going to be 10 years down the road, because that technology is not 10 years old, or it's not old enough to provide us with long-term outcomes.
Is it safe to say that we don't fully understand what long-term electrical stimulation of the brain will do in the long run? Would that be safe to say?
I think that, well, I mean, if I take it back a step, we do have experience with other forms of electrical stimulation of the brain, for instance, deep brain stimulation, which does deliver electrical stimulation in the brain in a slightly different way than RNS does. And that we have long-term experience with. The challenge is we can't exactly apply that knowledge to RNS because the way that RNS works is a little bit different.
Okay.
So, you know, it's not completely uncharted territory, but it's just very, very difficult to compare apples and oranges, and very, very difficult to apply a base of knowledge on electrical stimulation in the brain and other devices to RNS, which functions in a very different way from other devices.
Okay. Reversibility and timing is next. Sorry, I'm having some trouble with the slides here.
No problem.
There we go.
Yeah, so when it comes to reversibility and timing for resections, I mentioned earlier that these are non-reversible procedures. When we do a resection, for instance, remove the temporal lobe or remove the frontal lobe or other areas of the brain, that is a permanent procedure. There's no way to reverse that once it's performed. And in terms of the timing of it, we can do resections or disconnections as early as we'd like, you know, obviously with some reasonable considerations, but for instance, procedures such as hemispherectomies can be done at a few weeks of age, you know, often in little children. So the effects are permanent and there's no limit on the timing of the procedures. But when we look at RNS, on the one hand, it's reversible, which is good. So for instance, if the electricity is turned on and there's an adverse effect, or if there's an effect that's unwanted, the electricity could be dialed down, and at least in theory, the vast majority of issues related to the electrical stimulation are reversible. That has to be balanced though by age limits. And we know, there's increasing knowledge and appreciation that the earlier we treat epilepsy, especially during critical windows of neurodevelopment, the better the outcomes are. That recurrent, uncontrolled seizures are not healthy for a child whose brain is growing, whose brain is developing, and we want to give all children the best possible advantage during critical windows of development when they're younger. And RNS, as we heard earlier, does have age limits. You need the skull to be a certain thickness in order to place the RNS device. And some families with young children may choose to wait until the child is old enough and the skull is thick enough to implant the RNS. And again, there's no right and wrong answer. This is just a factor that weighs into your decision making. And one notch against RNS would be that it's important to control seizures at younger ages during critical windows of development. And in young children, waiting until they're old enough and their skull is thick enough to support an RNS device may be disadvantageous.
Yeah. And then access.
And finally, access. This is the other issue that we thought was relevant to the decision for RNS versus resection. We know that resections are widely available. And I do say that with a caveat that, of course, all children with epilepsy need to be evaluated at a center that has expertise, at a center that has experience, and at a center that has the multidisciplinary team to care for the children before, during, and after the surgery. So, the resections are readily available at certain specialized centers for the treatment of pediatric epilepsy. For RNS, I would say there are more barriers to access. Some of them are regulatory. As you heard, it's currently only on label in adults, not in children, though I expect that will change over time. There's also other barriers to access that may limit their use or potentially delay the ability for families to acquire RNS. And as we heard about, delays in treatment of epilepsy may not be so great for especially younger children or individuals that are in critical periods of their neurodevelopment.
Okay. So here's your model. At the end of the day, it's broken down into 5 steps, which I think when I was looking at this, I feel like this is what just about most of the families are already doing with the way you've laid it out. Terrific. What I is this really requires two-way, honest conversations with the child's team. And I'm not sure a lot of physicians or surgeons and neurologists sometimes have the time to do this. I know, I hear of families saying we only had about 1 hour meeting with the doctor or the surgeon and we had to come to this decision. So something to think about when we're talking about this is let's make sure that there's time to do all the things in the framework.
Yeah, and this is really your point is really, really important, Monica. Thank you for raising it, which is we all do this on a daily basis. This framework and these decisions are by no means something that is absolutely groundbreaking or something that's very, very different from what we do. But by explicitly stating every point in this process, it gives us then the ability to check off whether we've done that, whether we have crossed that bridge before going on to the next. And it helps structure the conversation. And potentially it helps some families and some clinicians to present these options in a way that is most relevant and in a way that's most helpful for families to ultimately make the decisions about which therapy to proceed with. But these are already steps that we all do on a regular basis in deciding between different options when it comes to medical therapy, and in general in deciding about different options in life. This is a framework for decision making applied specifically to the challenge of surgery in eloquent cortex, particularly when faced with different options. Okay. So the first part of the decision-making model is to identify what the options are. And this is really, really important. And again, I'm not saying this as something that is brand new. This is something that is so self-evident. It's in front of all of us. But sometimes I hear from families that they don't know what their options are. And unless you specifically pause for a second and in your mind try and identify what the options are, you may get ahead of yourself and go to the end of the decision-making model before you've even taken the first step. So this decision-making model is not meant to be something that is completely novel, completely unusual. It just provides families with a fulsome way to make a stepwise decision that then makes the decision-making process easier. Yeah. And the first step is to involve a multidisciplinary group, a neurologist, neurosurgeon, neuropsychologist, social workers, linguists, to look at the different options. For some families, after a multidisciplinary decision or multidisciplinary evaluation, it's quite possible that a resective procedure isn't an option, or potentially RNS isn't an option, or there may be better options out there instead of a resective procedure or RNS, for instance, disconnective procedures or other tools at our disposal. So the most important step is the first step, which is to identify your options, because you cannot make a decision unless you know what your options are. And this sounds so simple, and yet we hear from time to time that families didn't know that options were available to them.
This is such because of the barrier, the comprehensive face evaluation out there for our families. It's part of what we're trying to do with this educational series is you have to understand what your options are. You have to have all cards on the table before you make a decision, and you can't do that if you haven't had a comprehensive epilepsy surgery evaluation. So if you're watching this for the first time, families, go back and look at our phase 1 and phase 2 evaluation webinars, because you can't even get to this step of identifying the procedure if you haven't had the right evaluations in the first place.
Absolutely. That is so critical. We need all the information that we can get to know whether something is an option or not. And information when it comes to epilepsy surgery truly is power. And the more information that we have, the more informed decisions we can make. And you know, I can't emphasize that enough.
All right. After we've identified the procedures that are possible, what would be the next step?
So once the options are identified, then I would go to the slide that I talked about. List the pros and cons of the different options based on values, based on the values that you have as caregivers and as patients. Ask questions as much as you can to try and develop some sort of system to devise the pros and the cons. And as we talked about in the last slide, we have some recommendations about some of the smaller steps in this process to help break down this larger decision into smaller components. And those small components would then help you distinguish between the different options that you have. Because when you're given the choice, resective surgery or RNS, that's not really a choice. That's too complex of a decision. You need some means to distinguish between the different options. And to distinguish between the different options, you have to have micro decision points. And those micro decision points have to be able to separate the pros and the cons of the different options that are presented to you.
Yeah. I think the point about how much do patients and caregivers want to know is important in this piece. Even we have been criticized about our website having too much information on it, that some parents may not want to know everything, the big procedures. And we have other parents who will say, oh, we love all the information on your website because we want to know everything. So really important for parents to kind of step back and decide how much do you really want to know about what may or may not happen after surgery before you factor in as part of the decision process.
Absolutely. And my recommendation to all folks who are listening is, you know, knowledge really is power. And the more knowledge that you have about what the future will look like, the more you ask your surgeon questions about these different micro decision points, the more you'll be comfortable with the decision that you make. And at the end of the day, no two children are alike. No two epilepsy syndromes are alike. No two families are alike. And different treatment options are reasonable for different children, and that's okay. But at the end of the day, making the right decision for the right child involves asking these questions and breaking it down into smaller steps that help you distinguish the advantages and disadvantages of individual treatment options.
Yes, absolutely. And then we would rank, right? So now that we have all this information, how would we rank?
Yeah, absolutely. So once you have the information, once you're able to somehow dissociate the different advantages and disadvantages of the two or more treatment options available to you, one would then rank them. And this is just a tentative process because then evaluation comes next. But rank them based on personal goals, health objectives, cultural values, whatever is important to you. And the most critical step of this, that clinicians cannot answer, this is a discussion with families, is what is your subjective experience with epilepsy? How does epilepsy impact your child's life, your family's life, and how can the treatment then influence that in a meaningful way? And
Yes.
that is really the most important question to ask when it comes to ranking which option is the most helpful to you.
Our son had hemispherotomy at 3 months old, and I remember people looking at us like we were crazy to even think about this surgery. We were actually begging the surgeon to operate sooner. And when we talk about this subjective impact of epilepsy on the family when he was seizing uncontrollably for months, it impacted everything we did. He couldn't even nurse, he couldn't do anything. So for us, it was very easy to rank that very rare procedure at the very top immediately because of what it was doing to him and how it was impacting our family. Absolutely.
Yeah, that is and thank you so much for sharing that because that is so helpful. And again, we do this all on a daily basis. We do this all in every decision that we make. We go through these steps and we go through these phases, but laying them out explicitly, thinking about them explicitly, not only helps the family with decision making, but it helps structure the conversation that you have with your surgeon. And it helps structure the conversation that you have with your neurologist so that together we make the best decisions for the families and also so that the clinicians, your physicians, understand what's going through the families' minds as they're making these decisions so that we know what the expectations are and we're all on the same page to help the child and the family really achieve those goals that are laid out for them.
Yeah, absolutely. And then once we've ranked, we evaluate. How do we do that?
Yeah, so the rank list now is done. But before you hit the submit button and you know you proceed, take a minute to evaluate. And this is a little audit. It's just a step to give you a little bit more certainty in your rank order. Why is one treatment better than the other? Which factors influenced your decision to put your rank order in the way that you did? Are there other mitigating factors that you didn't consider that would then be applicable that might change your rank order list? And this is a conversation again with the medical team, because sometimes maybe the medical team can offer one or two different factors that the family isn't aware of. One potential is some families live really far away, very far away in rural Canada, right, where I am. And some treatments can be really difficult. The families don't appreciate the difficulties of traveling back and forth to our center if it requires really close routine follow-up. That's one example of a factor that often families don't consider or hadn't considered in reviewing the different options available to them. There's a myriad of other factors that could potentially weigh into the rank list, and it's really critical to evaluate the different factors at play through an honest, two-way, comprehensive conversation with the treating team, because everyone needs to be on the same page and everyone needs to have really effective, really honest, and really clear communication.
This is, if there are any surgeons listening, I'm not sure that this is targeted for families, but please understand that these are such difficult conversations to have in the first place. some of our families feel very rushed during these appointments when they're asked to make a decision quickly because they want to get them on the surgical schedule. And I hope that as professionals, you're having conversations amongst yourselves that let's not rush the actual appointment, right? Block out 2 hours of time for these families. I know it's different in the US when you have to pay insurance, but these are not 30-minute conversations that you have, and they may be multiple 2-hour appointments. Make yourself available because these are big procedures that we're talking about. I used to say it's not a knee surgery my son is having, and I used to go in with very long lists for our son's surgery. He'd kind of roll his eyes, but he would be fine because I wanted answers. So have some grace with us, the families, because we're not surgeons, we're not neurologists, we don't understand this, and we're looking to you to help us understand. So thank you.
That is a very, very well said. And I don't know if there's any surgeons or healthcare professionals listening to this, but what I do, this is actually for all surgeries that I offer, not only epilepsy surgeries, unless it's something that's quite urgent and a decision really needs to be made immediately. And in neurosurgery, obviously, there's many cases where that is the situation. But when it comes to the majority of epilepsy surgeries, I walk in and the first thing I say is, today we are not making any decisions. Today I'm giving you information. We're going to meet again down the road. You're going to have questions that'll come up between now and the next meeting. We're going to address those down the road. We'll make a decision together in the future. And immediately that, everyone just breathes a sigh of relief that the goal of that visit is not to make a final decision. It's not to even evaluate. All it is to identify, distinguish, and potentially rank. That would be the goal of the first visit. And then subsequent visits would be to evaluate, to review, and then to click the submit button and to proceed with the decision that we make. And I think that's really, really, really critical. And it takes the stress off of the first visit, sometimes the second visit as well. Just acknowledging that no decisions are going to be made in the first visit. It's just to give information.
Yeah. And then the last step is review. What do you mean by that?
So this is at a later date, discussed with family, friends. This is going outside the bubble, outside of the care team for subsequent discussions, because families often will come back and say, I talked to my uncle or my brother-in-law or a friend, and a new perspective was given to me. And based on this perspective, I have more questions, or my values changed, or my opinion changed. Is there, can we have more conversations? And the answer is absolutely yes. There's always room to review the process. And this is really the last step to when you file your taxes, it asks you to review before you click the submit button. This is to review a summary of everything. All the options, the distinguishing features, your rank list, the values that go in evaluating your rank list, to look it over once more. And once you do that, then with confidence, with certainty, with a collaborative approach with the healthcare team, who are there with you obviously at every step of this process, we can proceed ahead with surgery, knowing that we've made a very informed decision for the child.
I think sometimes family and friends, however, can push back a lot because they don't understand the epilepsy, or they don't understand the effects of the procedures. We have these biennial family conferences, and one of the things that I really like is when people bring in parents and grandparents and that kind of thing, so that they can see what the outcomes are. A big proportion of those children are hemispherectomy, and you say that to a family member. I mean, we didn't even tell my mom because she would have had a heart attack. She would not have been able to understand it. So in part of this for families, you do have to be careful with some of the myths that maybe family members may believe. I have a family right now who, because of cultural barriers, is having a very difficult time telling her parents that her child needs a very big procedure to stop infantile spasms. You know, these spasms don't look catastrophic, right? They're they look mild, but we know that they are. So it's difficult for her now to tell mom and dad, this is what we need to do to stop these seizures that everyone thinks are not a big deal. I think this part is really challenging personally. So yet another kind of hurdle that parents have to overcome when they're doing this.
Absolutely. I couldn't agree with you more that this is, you know, sometimes we're a bit sheltered in our bubble and in our little decision making community. But of course, you know, we interact with people in our everyday lives, and the more that I think we draw them in, and the more that we educate, and the more that we normalize treatments for epilepsy that can help children, right? The more of a service that we make for our patients and also for future patients, because there is still, unfortunately, so much stigma, and there's still so much fear and anxiety, which I understand completely. But and certainly this decision-making model by no means aims to address all of that. But the more that we engage the outside community in general, I think the better off we are as a team taking care of children with epilepsy, both present patients and future patients.
Yes, absolutely. We're going to take this paper and turn it into maybe a 1 or 2 page checklist, something that the parents can use when they're processing these decisions. We already have a list of questions to ask the surgeon. It's a pretty long list, but our families do use it. And I want to thank you for this great presentation. This was terrific. Again, really difficult decisions our families have to make, but this is one way of making the decision-making process a little bit easier.
Thank you so much for having me, and you know, it's always such a thrill. I went to one of your meetings, of course, last year, and I absolutely loved it. It was one of the highlights of my year, and one of the best meetings that I've been to. I learned more from families, and I learned more from my families than I ever teach. So thank you so much for including me in this.
Oh, well, we'll have you back for our next conference. Now you'll regret saying that.
I'm on tape, so I look forward to it.
All right. Thank you very much.
Thank you, Monica. Take care.